Okay, so when it comes to treating high blood pressure or hypertension, there are a couple of physiologic feedback loops that we can target. So, first of all, whoa, come on, buddy. Great. First of all, we can target the cardiac output, and cardiac output is measured as heart rate times the stroke volume. And the stroke volume is how much blood, the percent of blood, or how much, like a physical, that's supposed to be a percent, blood leaves the ventricle during systole. In American terms, it's about 3 tablespoons of blood, which is about, like 15 milliliters, right? Okay. So we can lower the heart rate, lower the strength of contraction by affecting cardiac output. If the heart is beating less times a minute, then there's going to be lower levels of blood in the circulation. So that will lower the blood pressure. Then there is the biochemical rule where sodium goes, water follows. About 92% of the plasma is made up of water. So that water can be increased when sodium goes really high, because sodium will go into the bloodstream, water will follow it, and that will shift the plasma volume. Then we have a target of the physical nerves that attach to either the heart or specifically to the arterioles. If you can lower the tension of that smooth muscle, then you can decrease resistance, which is going to limit the pumping of the heart so it doesn't have to beat as strongly. And that's also going to lower pressure because you're going to have looser, more open blood vessels. So this can be done with normal vasoactive substances that are circulating in the body. We've got a couple of those around. Adenosine is a vasodilator that's produced by every tissue to dilate blood vessels and increase blood flow to that organ. Serotonin, histamine. And what we're going to be talking about first is how we can target this nervous system input to help lower blood pressure. All right, so thinking about the receptor types, remember in blood vessels, we have alpha-1 receptors predominantly, and there's also going to be some alpha-2 receptors. What drives this inhibition is that presynaptic receptors, so see how this is before, this is the synapse, the space between 2 neurons. Presynaptic receptors are called auto or self receptors. When a substance binds to that, so this neuron would be releasing something, and there would be so much of it in the synapse that eventually some of it is going to diffuse up here, bind to this alpha-2 receptor, and that alpha-2 receptor is going to send a message to the inside of the cell to say, stop making more norepinephrine. We have enough down here, so just chill. So this is our even number presynaptic inhibitory receptor. So we can target alpha-2s. We also have alpha-1 receptors as typical postsynaptic and then excitatory receptors. So that means norepinephrine typically would bind to alpha-1 receptors and then turn on whatever that cell's job is. So if it's to contract, that would increase contraction. So you can give medications that either enhance that, so they can agonize alpha-1 and increase blood pressure, like we see in cold medications, or maybe we want to block those alpha-1 receptors for vasodilation. Okay, alpha blockers. So the same way we have beta blockers, there's alpha-1 blockers, antagonists. So they bind to those alpha-1 receptors. If we just go back for a second, they bind to alpha-1 receptors. And instead of stimulating them, they bind and then block that receptor. So that would be a competitive type of action. So instead of norepinephrine binding, now this drug is there. So those are called the zosins. So they should be easy for you to pick out because they all end in zosin. They're not as efficient as other medications we'll talk about in treating initial hypertension, but they can be used as an adjunct therapy, or if their initial medications weren't as effective or safe as we wanted them to be, they can be used as a second line, but more commonly you'll see these as an adjunct therapy. So in addition to another medication, alpha-1 blockers, the zosins, are pretty good at reducing blood pressure and then helping to prevent the resulting overload on the heart and then the heart failure that might result as a response to that. So alpha-1 antagonists, those are the zosins. Those are going to block alpha-1 receptors and block contraction stimulation. Some zosins, again, they should end in zosins. We've got doxazosin, prazosin, terazosin. These are sold under a variety of different names. Doxazosin is a selective alpha-1 blocker, which means that it has less side effects. It's specific. It's really good at binding to those, blocking them. They're taken orally to help relieve the tension of smooth muscle on vessels. Prazosin, sold as names like mini press. It's a competitive alpha-1 agonist. Antagonist, obviously not an agonist. That's a mistake. Let's make sure we say that. It's an antagonist. See, antagonist. It's a competitive antagonist, which means it competes for the receptor site with norepinephrine. And when those are blocked efficiently, you get vasodilations of especially arteries, but there's smooth muscle and veins also. So it limits overall, sorry, my dog did something bad and I acted very calm. It limits the resistance systemically. It's a really great treatment for long-term management of hypertension. It's been shown to be safe over years and months, so that's your prazosin. Terazosin, this is something that is really potent vasodilators. It is started at a dose about 1 mg. And it should be taken at bedtime because it causes such a large drop in blood pressure that it's safe when you're going to sleep and just laying there to not worry about any changes to consciousness or postural or orthostatic hypotension. This dose can be increased to even up to 10 milligrams as needed if these are taken with calcium channel blockers, which are really potent medications to limit the strength of contraction of the heart. Those are contraindicated because there's such a lowering of blood pressure that that wouldn't be helpful for life. So that's taken at bedtime. Everybody starts at 1 mg, and then it can be increased as needed. Try to prevent mixing that with calcium channel blockers. That will cause an unnatural, unhealthy drop in blood pressure. Side effects of these alpha-1 zosin medications, these antagonists, there is the first dose effect, and that's referring to that postural or orthostatic hypotension, where when people first take this medication, the blood pressure is really steeply decreased. So when you stand up too quickly without waiting for a blood pressure adjustment, it causes so much vasodilation of vessels that they don't appropriately contract when they are stretched, which means when you go from laying down, so if you're laying, then your blood's pooled, and then you stand up, and then your blood is going to pool in your lower limbs. What happens is the myogenic mechanism states that smooth muscle, when stretched, responds by contracting. So when the blood pools down in the lower limbs, that stretches the vessel walls, and then the smooth muscle responds by contracting. So that shifts the blood flow up, and then you're happy and you're, fine, awake. When that doesn't occur, when there's a failing of the myogenic mechanism, there isn't a really strong contraction of the muscle. It stays dilated, which means that the blood is not going to necessarily get to your brain as it should, which means you can feel really dizzy or actually faint. So that's why taking these things at night is helpful without changes to, again, consciousness. Less common side effects, headache, that can be associated with vasodilation in general. Because these are pills, we know all oral medications are associated with GI upset. Ventricular palpitations are a strong, like, tachycardic response originating in the ventricles that can indicate beats that are skipped and the heart trying to withstand the systemic blood pressure. Feeling weak, weight gain, increase in lame cholesterol. The L is for lame. Your low density lipoproteins is the bad cholesterol. And in order to have an erectile response, remember the blood flow is going to increase to the genitals, and same type of thing, we're going to have vasodilation to have the erectile response in the clitoris and the penis. If there's so much vasodilation from these medications, that is going to be an interrupted response. So there can be erectile dysfunction in males, and then difficulty reaching climax in females because of alterations to the blood flow. Okay, there is a suggestion that alpha blockers increase the risk of heart failure with long-term use. That is something that is in the back of physicians' minds, should be in the back of your minds. It hasn't been confirmed in really long-term studies. More data is needed, but when you look at data from people who have died due to heart failure, they start to notice things that are in common between them, and what they saw is that large amounts of those patients were on alpha drugs. So that is something that's been suggested, but we don't know if that's a causation type of response or just a finding. Okay, then we have our alpha-2 receptors, our presynaptic inhibitory autoreceptors. So if you activate them with, if it's alpha or beta, it's norepinephrine. So if these are activated, if we agonize them, then we can turn off creation of norepinephrine from the presynaptic neuron. So alpha-2 agonists, they stimulate alpha-2 receptors. So these would act hopefully right in the centrally acting brain areas. So this would send a message up to the medulla areas that send constrictive messages to help decrease the heart rate. These aren't widely used because they are they're expensive. They can be kind of dangerous in some cases, but drugs like clonidine, we're starting to see an increase in their popularity because of their effectiveness at appropriately treating blood pressure, and then also having the desirable side effect of lowering things like anxiety, panic disorders, perseverative types of things. Alpha-2 drugs can be prescribed with a diuretic or alone, or they can be used as an adjunct therapy. They're not typically the first choice and the only drug for lowering blood pressure. That's usually where the beta blockers come in. You usually start to add other things, either if it's unsafe to use a beta blocker or if the patient isn't responsive to the beta blocker. Okay, so some different alpha-2 drugs. I mentioned clonidine. This is a really popular one, sold as a million different names now. Catapres, Capfe, Nexiclon. It's an oral medication. It can be taken up to 2 to 3 times a day with an ascending dose, meaning it gets to a higher dose later in the day because you're going to go to sleep, and it's okay if you have a really low blood pressure then. It does interact with alcohol because it is a vasodilator, and alcohol is a vasodilator. You can have really potent vasodilation and then definitely headache effects. It has been shown, because of its interactions with alcohol and causing excessive sedation, that it can decrease some patients' drinking, which again can be a desirable side effect. Then we've got guanabens, sold as Wytensin. That's an oral med taken twice a day. Another really common medication, the generic is guanfacine, sold as, again, a million different things. Intub 10x, taken for blood pressure or for anxiety type disorders. This can be extended release, taken orally once a day. There's also short-term or immediate release formulations of guanfacine that would have to be taken multiple times a day. It generally takes 2 weeks to experience this effect because of all the alterations that the neurons will make to their receptors in their expression. So once all of those alterations are made, it should take hold in about 2 weeks. Okay, methyldopa, sold as Aldomet. So methyldopa is an alpha-2 agonist. Remember, dopamine is part of the catecholamine family, meaning that it leads to the creation of epinephrine and norepinephrine. So methyldopa is a preparation of a form of a precursor of dopamine which targets the alpha-2 receptor. It can be taken as a tablet or a liquid 2 to 3 times a day. And beta blockers are the best drugs to take during pregnancy for things like preeclampsia. So methyldopa is chosen to be suitable for pregnancy. So you might see that if you're in an obstetrics case. Okay, because these things cause tons and tons of vasodilation and low blood pressure, all of the side effects are going to be associated with that. Again, dizziness, feeling lightheaded, especially when changing posture, feeling tired when your blood pressure goes down. That's usually a sign that it's bedtime. Your blood pressure drops a ton when you're sleeping. Headache. Dry mouth, that has to do with like more anticholinergic side effects. Remember, acetylcholine is released from presynaptic neurons in both sympathetic and parasympathetic. So if we're inactivating alpha-2, we're kind of hitting the whole nervous cascade. So you can see anticholinergic side effects. Remember, we take alpha or agonists to prevent congestion. So if you're giving a drug that reverses that, you're going to see congestion. Possible edema due to low blood pressure. Blood pools, fluid leaves the vessels due to high pressure and vessels being leaky, so you can see edema. Feeling tired, weak. Possible fever, depression, liver inflammation. So it's recommended that patients get their liver enzymes checked regularly. And again, sexual problems due to a interaction with the normal erectile response. Okay, so now we are going to go on to some different medications. We talked about our alpha drugs, so those are going to be targeting the nervous cascade. Now we're going to move on to beta blockers. So beta blockers are named beta blockers because they are antagonists for beta receptors. The predominant beta receptor on the heart is the beta 1, which is prevalent across the entire myocardium. And they have a little bit of a counterintuitive effect that I'll explain in just a second. They work differently than people think that they do, so I'm going to teach you how they actually work. So here we've got some beta receptors, and just to make life hard, they have even receptors presynaptically as we would expect, but you also see that there's the possibility to have even numbered receptors postsynaptically, because why should anything be easy? So just remember alpha, beta, by norepinephrine, odd excitatory, even inhibitory. Okay, so beta blockers are the olols. They should all end in olol, and ideally they would block just the beta 1 receptors, which are on the myocardium. However, there are also, as we saw, there's beta 2 receptors there too, just to make life hard. So some of them are specific for beta 1, but some are non-specific. They are dirty drugs, and they're going to hit all of the beta receptors and hit beta 1 and beta 2. Remember, that's dangerous because beta 2 receptors are where? Where are they? They're in your bronchioles. So we don't want to block beta 2 receptors because beta 2 receptors dilate the bronchioles. If we block that, we're going to get bronchoconstriction and then difficulty breathing. So they have a little bit of, again, a counterintuitive way of working with blood pressure. And what it does specifically, I'll draw this out for you too, it reduces cardiac output by physically changing the movement of responses from the AV or the SA to the AV node. So I'll explain that in just a second. But first, let's just look at our different types of medications. We've got specific, which means they're expensive, but they also are going to have less side effects because they hopefully only hit beta 1. I just want to say, though, that in the real world, we cannot truly be sure that they will not hit beta 2 because these look so closely like one another that can never be guaranteed, like anything else in life. But acebutolol, atenolol, betaxolol, bisoprolol, metoprolol, those are all beta 1 specific. The cheap ones are going to hit both beta 1 and beta 2 are your propanolols, cartolol, nadolol, pentobutolol, pindolol, and timolol. So all your olols. We had our zosins, our alpha blockers. Your beta blockers are the olols. Okay, so again, I'm just going to use an example of like a general beta receptor antagonist, like propanolol is one of the most common. Ideally, it would just block beta 1, but what it does is block all the beta receptors. So what we want at the end of the day is a decrease in heart rate and the force of contraction. We want to maintain vasodilation. We don't want bronchoconstriction, so do be careful with non-specific beta blockers if there are respiratory problems. It decreases glycogenolysis, so lysis is the breaking apart of glycogen, which is stored glucose, and also decreases glucagon secretion. Glucagon is what maintains your blood sugar levels when you're fasting, like when you're sleeping. Therapeutically, beta blockers are used for hypertension, for glaucoma, post-infarct, to help treat angina pectoris, any type of thing where there is high blood pressure. So let me just tell you how they work. So here's a heart, okay? Here's our SA node. So that's the node that's the pacemaker. And when this is activated by whatever, it could be the vagus nerve spitting out acetylcholine, or it could be norepinephrine binding here to the beta 1 receptor. These are mostly muscarinic though. So this is usually acetylcholine. So you've got acetylcholine binding to things like muscarinic receptors. So anyways, when the SA node is activated, that spreads a wave of contraction over the atria, and then eventually hits the next node, the AV node. So sinoatrial and AV. And then the AV node, when that's excited, that starts spreading its wave of excitation down this bundle of His, and that goes into the left and right bundle branches, up through the Purkinje fibers to contract the ventricles. That looks like a majestic pigeon. Okay, so anyways, when we think about a normal heart rate, we would say, yeah, for an adult, like 60 to 80 beats a minute, that's perfect for you. Great, good for you. When people have high blood pressure, that again can be due to a variety of causes, but the more times the heart beats, the more likely it is that the heart is going to wear out quicker. It's kind of like your car. If you drive it a lot, it's going to probably not last as long as a car that you drove once a week. So when you can decrease not only the strength of contraction of the heart, but the physical heart rate itself, that will prolong the lifespan of the heart and then hopefully prevent heart failure. So the way that beta blockers work is that they slow conduction through the AV node. I'm a beta blocker, and don't you know, I slow conduction through the AV node. And what that means is instead of atria contract, ventricles contract, it starts all over again, this is going to slow this spread of action potentials, which is going to mean that the heart will fill more than it typically would with blood. When you stretch a heart, just like a rubber band, to a greater degree, that's going to increase the force of contraction. But because we've allowed the heart to now overfill a little bit, it only has to beat once to send out the same, like a stroke volume. So the resting heart rate actually lowers. So even though it physically increases the strength of contraction, it lowers the resting heart rate. So the heart works less times over the lifespan than if somebody wasn't on it. So even though it's increasing the strength of contraction, which seems counterintuitive, slowing the conduction through the AV node increases ventricular filling and limits the amount of time the heart has to beat to deliver the blood out to the body. Isn't that magic? That's how they really work. You guys learn things.